Hi everyone. Welcome tonight's lecture regarding the OIG's compliance program guidance pertaining to individual physician and small group practices. This is one of the many lectures that we will be giving in according to our new compliance course that we're developing. So we will be discussing a lot of things in this lecture. So, for example, we will be discussing ways to develop a compliance program, the different things that's entailed in a compliance program regarding the individual physician and small group practices, the auditing and monitoring, establishing and developing standards and procedures, designation of a compliance officer or contacts, conducting training and education. And there's so much involved in compliance, but especially in healthcare, education is an important part of every day-to-day basis or day-to-day life in medicine. And then responding to detected offenses and developing corrective action initiatives. And then the next thing will be developing how to develop open lines of communication. That's an important part, especially in a small practice or a physician clinic. And then the last, we'll be discussing enforcing disciplinary standards through well-publicized guidelines. So, for example, that anything that new changes or there's any disciplining actions based off of certain consequences that an employee does, there are strict things, everything's set in stone in a way that people are able to easily have access to those information, so they are aware of the possible consequences of not being compliant with the policies and procedures. So let's get started. So for this particular program guidance, the OIG had published this back in 2000. So anything that, even though it sounds like it's very old in a sense, it is still all the information that is contained within this document is pertinent to today. So obviously the overall goal of this program guidance is patient care. That's the whole, the priority or the goal of the physician practice. Always looking after the best interests of the patient. And so that's kind of like why we have, those ABNs and stuff like that, to make sure that what is being done, those services being rendered, are in the best interest of the patient. So there were a couple of things that the OIG has recognized as what a provider or physician group, kind of like the benefits, or how are they able to use the compliance program to its best. So first of all, there's the speed and optimize proper payment of claims. So making sure things are going smoothly, that even if you have denials, it is not a high rate of denials. And then whenever you are looking either, prospectively or retrospectively of claims, that, when you have a compliance program, you are minimizing those potential risks, those that the practice has, or they have indicated as a particular or potential risk for that particular group, which is why they have compliance programs. Now, before the Affordable Care Act, compliance programs were voluntary, and of course the OIG recommended them. However, since the ACA was signed back in 2010, I believe, that anybody that participates in the federal healthcare programs, Medicare and Medicaid, things like that, it is now a requirement to be able to participate in those types of programs. So like I said, we already talked about, a well-designed compliance program. It helps mitigate or minimize those billing mistakes. It helps patient privacy. That goes along with, HIPAA and the high-tech, those kinds of acts. Always, the best interest of the patient, protecting their health information. It's top priority. And then, other things, it reduces the chance, or those red flags that you always hear about it, for, the practice to be audited by CMS or OIG, fitting the potential outliers and things like that. And then, with compliance, there's always those laws regarding the self-referral, or, also known as the Stark Law, and then the anti-kickback statute. So, those two kind of go or work together in a sense. but these are also referred to as, the fraud and abuse laws. So, with the compliance program, you have something set in stone in a sense that providers or, that compliance contact is able to look into those policies and procedures, or there's, a in way that which they can, connect with if they have a, for say, a law department or, law advisories. Obviously, if it's a small practice, they probably not have that resource. So, that's why you work hand in hand. For example, if you don't have a compliance program and there's a physician practice management company that they have, and you can use their compliance program and then tailor it to the practice. So here I have indicated or included the link in which you can pull up the document that pertains to the individual physicians and small group practices. So here, the CMS encourages that the practice or physician, obviously the self-disclosures, any potential or any billing errors that they have caught during an audit or things like that, and that they're able to self-disclose that right, obviously as soon as possible. And as the next bullet states, that under the Affordable Care Act, Section 6402, that anything found in that self-disclosure and during that audit, any types of overpayment, that must be, identified and to be paid back within 60 days of finding that error. So there are a couple of different types of billing errors in a sense that's indicated for this particular section in the compliance program. It talks about fraudulent billing and then erroneous billing. So fraudulent, the same thing we're dealing with fraud and abuse, the differences between those two. Fraudulent fraud is, the willful act of doing things even though you know the correct way or the right way you should be doing it. So for example, with the intent to receive payment for services not being rendered. So for example, you are doing a service that you know is not covered, yet you are billing it as if it is covered. So that's an example of fraudulent billing. Erroneous is just like you don't know, you don't have the intention of committing fraud. So that's kind of relating to more of the abuse, that even though you may not be aware that you're doing it wrong, but it is wrong. And then that doesn't affect, the healthcare coverage, or in a sense, the money that's for healthcare. So knowing the difference between fraud and abuse, and if you are taking or wanting to sit for the compliance officer credential, some of those questions, it'll ask you being able to tell the difference between fraud and abuse, and and it pertains to different scenarios. So with every effective compliance program, the OIG has stated 7 basic components of a compliance program. So one being conducting internal monitoring and auditing. So, so there's all kinds of things that can be pertaining to this alone. And then implementing compliance and practice standards. So this is when you're possibly developing your practice of the standards and procedures. So those policies and procedures in which you are using and abiding, for either coding, billing, or documentation. And having that designated compliance officer or contact or contacts, to keep an eye on and monitor compliance for that practice. The OIG has noticed or acknowledges that a small rural physician practice may not have the resources to designate one particular individual employee as the compliance officer. So they may mitigate those different tasks to different individuals, employees within the practice. And then conducting appropriate training and education. So this pertains if there's a new coder coming in, what is being done, how are they being trained? Are they sitting with an experienced coder or someone that has been there at that practice for a while? What are the stepping stones, and what is the pathway for them? How long it's going to take them to be able to kind of go on their own. And then responding, how are you going to be able to respond to detected violations. So it kind of maybe possibly goes hand in hand with building of policies and procedures. If you find or you find something dealing with finding errors within your internal audit or external audit results, are you going to be able, what is the proper protocol and self-disclosing, or doing whatever you can to report those violations? And then developing open lines of communication. And then, so this keeps, kind of like the open door policy, that employees are aware of who they may be able to contact, any compliance issues. And then lastly, enforcing those disciplinary actions, like I said, through well-publicized guidelines. And that's the important part of compliance, is that you have well-publicized guidelines. So like I stated before, that OIG understands that a full implementation of all of those 7 basic components for an effective compliance program may not be feasible for all physician practices based off of the resources of that particular group. If they're in the rural area, they may not have resources. For example, if another practice may be in like a bigger city. And then it also depends on the specialty and the size of the practice and how they're able to implement all of those basic components into their own compliance program. So like I said previously, there are physician practice management companies in which you are also able to implement certain parts of their compliance program, and also then tailor that program to fit the needs of the practice. And so in doing so, you need to, after you kind of do that baseline audit, you're able to kind of see what are those potential risk areas for the practice, and definitely tailor those the policies and procedures, or those standards and procedures, and use that as a kind of a compliance guidance, and make sure that employees or the providers are following those what's stated in the compliance. And then you have physicians' participations, or the practice participations in these compliance programs. Like I said, before the Affordable Care Act, a compliance program was only voluntary. Obviously, the OIG recommended it. But now, since the Affordable Care Act has been effective or enacted, that it is now mandatory for anybody or any of those practices that participate in the federal healthcare programs. So whenever your practice is compliant or participates in the program guidance, it definitely augments any way it shows the effort on the practice's part to be more compliant. For example, if they find an error, what are they going to be doing to fix that error, or what is their corrective action? We'll be discussing that later on in the presentation. So the first thing, one thing that we had talked about earlier, is the auditing and monitoring. So a successful and an effective compliance program will show how is the plans or the programs improving in their compliance program overall. So I said, the initial step is to kind of define, what those standards and procedures should be for that particular practice, if it's a specialist or, this internal med, that you develop it to tailor it to fit that practice. Obviously, you don't want to implement the full, the program compliance program in a sense, all those 7 things. If the group does not have the resources, you got to think about what the practice is capable of using the resources that they have. So after you develop those standards and procedures, the next thing to do is conduct that baseline audit that I discussed earlier. So this will kind of look at the practice's coding and billing patterns, and kind of, how they're able to find ways to improve if they find any, detected errors and things like that. So with those baseline audits, it kind of gives them that starting point and that framework to build their compliance program, or those standards and procedures. So I don't know what happened here, but with the 5 or more, if you're dealing with a federal payer, kind of the OIG has recommended to use 5 or more medical records per federal payer. And then when it comes to physicians, if you're looking strictly at physicians, the, do 5 to 10 medical records per physician. Sorry that got cut off. It wasn't like that earlier. Um, so definitely just keep that in mind whenever you are doing a baseline audit. A lot of OIG kind of recommends about 5 to 10 records. So there are a couple of different things when it comes to audits. You can have the internal audit or an external audit. Obviously, internal audits are less expensive since they are already within the practice. But also, there are pros and cons to everything. So when there's an internal auditor, they are a little bit more biased since they are there. They are within the practice. Um, so, there's potential, risk factors dealing with, cover-ups of, those errors found within an audit, or, proper education is not being done. And that's, crucial, to show the effectiveness of a compliance program, is that when errors are found, what is being done to fix or correct those actions. And then you have your outside vendors, your external auditors. And with that, those people are usually unbiased because they're coming from outside the practice. It's basically a new set of eyes. And OIG has noticed that even if you have an internal audit department, it's beneficial to have those external people to come in and to audit those records, or audit the practice or the group or whomever it may be. Um, and, it kind of gives a different, like I said, different eyes on those records. It comes from a different background, and it's OIG has found that to be very beneficial for groups to use external audit companies. So there's a lot of benefits to finding with the use of the baseline audit, obviously. So this kind of looks at, say, are these bills or the claims accurately being coded and reflect the services that are being rendered. And this is a documentation to support those services. So, and then another one is, is the documentation being completed correctly? Are the notes signed off? There's all kinds of stuff that goes into this. Obviously, there's difference between the handwritten note and an electronic note. And then obviously all those services that are being rendered, are they medical necessary? Medicare really focuses on those things for medical necessity, and of course, what meets medical necessity for Medicare may be different from a different payer. So definitely being able to understand the payer policies and procedures um, is really important, and not only for the sake of the practice, to decrease those rejections or those denials in your practice. But it helps overall with the reimbursement of everything. And then looking for any incentives, of unnecessary services that exist. So a baseline audit can look for like referrals. It's a great way to make sure that people are compliant with the anti-kickback statutes, or the Stark laws, or the physician self-referral laws. So that's, there's many different benefits to a baseline audit. So, definitely use these to the best of your advantage. And that's, like I said, OIG uses it different ways. It's, obviously cheaper for those to use internal because they're already part of the payroll, rather than paying somebody extra from outside to come in. So, for pertains to medical records, they should also be reviewed, not only the claims, but they should be reviewed in compliance with the coding and billing documentation requirements, especially, per payer. And that's kind of why they look at, you can do that baseline audit, like 5 to 10 charts per payer if you're looking at from payer to payer, or those physicians. So we've talked about these type of audits before in previous lectures. We had the retrospective audit or the prospective audit. And those retrospective audit is when when individual reviews claims on medical records after they have already been paid and submitted. And then you have prospective audit, which is when an individual looks at medical records or claims before they're submitted to the payer to look and make sure that they meet those documentation requirements, or those coding and billing requirements, to make sure that the services are being rendered, and also to make sure that those requirements are there based off of those payer policies and guidelines. So, there's different varieties. I know from the company I work at now that we do both the retrospective and the prospective audits, and we have found it very extremely beneficial. With retrospective audits, you are able to, you can find like possible missed opportunities. For example, if a provider has not been, capturing amputations, for example, they have been capturing those in a long time. Obviously, that plays a role in their medical care. Do they have phantom limb syndrome? Obviously, amputations or amputees have that condition. It obviously depends on the individual. And then prospective is, you can sit down with the provider if you're able to do so, based off of your relationship with your provider, and work with them and say, okay, what are you documenting it for each of these conditions? Is there support in your assessment and plan for each of these conditions or each diagnoses that you have listed in your assessment and plan? What is being done? A lot of providers think that you have to write a book for each diagnosis that they assign or list in the assessment and plan, but that's not true. You can easily, as simple as conditions improving or it's worsening, or it's being monitored by Dr. So-and-so, are there any medications, and linking those things. And you can do simple things that you can easily type up, show the connection as to, how is it being monitored, evaluated, assessed, or treated. You hear a lot about, the meat when it pertains to risk adjustment or Medicare risk adjustment, or just risk adjustment in general, really. So, there are major benefits to both of these aspects of these different audits. So we'll be continuing about the auditing and monitoring section of a compliance program. So obviously, OIG recommends annual audits, whether it be the internal or those external audits. And then when it pertains to the audits revealing educational opportunities, how are you going to be able to approach the provider or whoever needs to be included in this educational opportunity? Is it staff or whomever is, instrumental into the creation of that medical record? So there's a nurse needs to be involved. There's a medical assistant needs to be involved. So definitely need to keep an eye. We're going to talk about this later on when it talks about the continuing education, or continual training and education. And then it comes to the audit sampling. We talked about this in the previous lecture as well. Is it going to be a random audit? Is it going to be a focus audit? So random audit is basically that it could be for providers, throughout the practice. It could be, the modifiers, or it can be the E&M leveling, things like that. Focused audit, obviously, it stands for itself. It's more focused. It has a goal in a sense that for example, the focused audit is just going to be on claims that were submitted with a modifier 25 appended to the E&M, or to whatever. So, that's the difference between the random and the focused audit. The focus audit may just be one for a particular diagnosis code or a particular provider rather than everybody in the practice. So knowing the different auditing samplings, is another part, in creating a compliance program, or, continually improving and improving that compliance program or those standards and procedures. So the next section is establishing practice standards and procedures. I normally just say policies and procedures, but I'll do my best to say standards and procedures. So after the internal audit or those external audits, those baseline audits, identify, the potential or those practices, or the practices risk areas. And the OIG's guidance for individual physicians and small group practices, they list a couple of risks that they notice when it pertains to individual and physician practices. So when it comes to these standards and procedures, they should be appropriate to the practice size. Like I stated before, that the size and specialty plays a factor in developing a compliance program. Obviously, if you're a psychological practice, you wouldn't be, seeing it for, endocrinology or something like that. So obviously, you need to tailor and change in your compliance program to fit the needs of the practice. That's what OIG stresses a lot, to fit the needs of the practice and those risk factors associated, with after finding or doing the baseline audit. Make sure that these standards are drafted in a concise and easy to understand language. This especially goes for, those policies and procedures pertaining to payers. So if you're looking at, pairs, then use specific words, and it may seem complicated that you can't comprehend it. So it's easier, or it's best to, whenever you're creating your standards and procedures for your practice, that you're able to use that in an understanding, or in a way that people can understand it clearly, that if they have questions, you may be able to answer them. But you don't want it so complex that people just kind of throw it out the window, in a sense. So definitely is the best way to, get across the importance of the being compliant with this program. So there's a couple of things, we had talked about those well-publicized guidelines, and then, you have your little binder that has all the standards and procedures for that practice. So you have, you can put those stuff in the binder, and, OJ talks about, all the different clinical forms or those treatment guidelines that, pertain to that particular practice. That you could even possibly find your ABNs for that practice in there. So, there's all, you need to have that place you can go to find all of those standards, but in another way that your employees are able to know, okay, where can they go to find this information? Is it well accessible to them? And that's an important part, because we'll discuss later, that if any changes are made to these standards and procedures, the employees must be, made aware of the changes, whether, a email or posted on, there's usually a compliance board, or, when it pertains to OSHA, you always have to have that OSHA standard, the OSHA board, in the well-publicized area. So definitely finding different ways in which you can, give this information to to your employees when things have changed. So like I said, if there's any updates to these standards and procedures that are necessary, the employees must be told. It is so important that they are told. Obviously, if you want to have a compliant or an effective compliance program, that if your employees are unaware of the changes and they're still doing the old ways, then there's no way in which you can, use disciplinary action on them if they're not aware of the changes, because they weren't told. Um, and yeah, there's obviously different ways. If they don't listen to it and they're just stuck in their own ways, then yeah, that can be an issue. But continual education is an important part, and we'll be discussing that later. So new employees, they should be trained in those standards and procedures upon their orientation or upon their arrival to the practice, and whenever they begin working or begin their employmentship. And so all of this training that is done, they must be documented in their human resources file, and then have that signature of the employee and the supervisor's signatures. This is kind of to know that they have either received these standards and procedures, and they fully understand and will be compliant with them. And then you obviously have your supervisor's signature there. So this kind of covers everybody, that they received it, and it covers the facility as well. That it indicates you have documentation to show that they've received it and they will be compliant with it. I don't know what is going on with this. This is not what I was doing earlier. So the OIG has laid out specific details, pertaining to the risk areas that are listed in this box. So the specific risk factors that goes along with individual physician and small group practices include the coding and billing, obviously, documentation, reasonable and necessary services, and then improper inducements, kickbacks, and self-referrals or Stark law. So obviously we always talk about documentation, especially I do, and I think it's an important part, not only to indicate what was done during that encounter, but it also supports everything that the provider does during that encounter. And it also kind of, it helps with the patient as well. It definitely helps with the quality of care that the patient receives when there's proper documentation. Also, if the provider goes to, not sorry, if the patient goes to another provider, um, and there's poor documentation in the records, the other provider may prescribe something that they may be allergic to, or something that may interact with another medication that the patient is on. So when there's improper documentation, it could lead to many different things. Obviously, coding and billing errors, pertaining to small group practices and individual physicians. And then when it comes to making sure that all the services and items rendered during that encounter meets medical necessity, especially for Medicare, they have their own, guidelines and policies pertaining to, what's required in documentation or what's required to meet medical necessity. And then lastly, those improper inducements, those bribes, things that influence somebody to do something, and then kickbacks. So it's dealing, what are they doing, what are they going to be able to get back, for doing certain things. And then self-referrals, it's pertaining whenever a provider has a connection of the family or financial ties to, a designated health services such as a lab or physical therapy, and they have some kind of connection there, what is being done, to for those referrals. And that's an important part when it comes to making sure that the physicians and the group is being compliant to Stark law. So when it pertains to the coding and billing risk factor for this compliance program guidance, the OIG notices that this is a major part of the compliance program, obviously for many reasons. One being like the reimbursement is how everyone's paid. Obviously, if there's a lot of abuse and fraud, things being done, is due to the coding and billing mainly. So this is why, the coding and billing is pretty much in every one of the compliance program guidances that the OIG has published. So some of the common things that is a trigger for an investigation either by CMS or OIG, like I said, billing for services not rendered or covered when it is not covered. Double billing, duplicate claims, upcoding, unbundling, the misuse of a provider identification numbers. For example, that a provider doesn't have a number yet, but they use somebody else's. That's one of the examples that's, that OIG discusses in this program guidance. So, keeping an eye, kind of, it's like a red flag kind of thing for OIG and CMS. So definitely keep some of this in mind. I know this kind of popped up on the compliance exam, knowing those specific risk factors and, being able to look at a scenario that they have, and say, is this double billing? Is this unbundling? Is it upcoding? So definitely if you're interested in sitting for the compliance officer exam, definitely have an understanding of these program guidances, because they will be all over the exam, especially regarding this lecture tonight. A good section of the exam is from the individual practice and small group practices compliance program guidance. I believe there's like 30 something questions. So it's a good chunk of the exam. And then, whenever an effective compliance plan or program will identify and prevent mistakes because the staff will ask questions, based off of what's, they have on their standards and procedures, or they come to them because they have some questions because it's not very clear, and if those things are unclear, and you come to understanding that things need to be modified, that's in a way that you can show that you are trying to be as compliant as possible and documenting those activities. That's an important part. OIG recommends that you capture, you document every activity that is done, to show, indicate that you are implementing your compliance program. So again, in an effective compliance program, I don't know why that came again, but so after an audit or review is done, uh, there's a couple of different things. Either there's an error, and then what is going to be done to correct that error. If it needs to be an overpayment, what needs to be done. And like I said earlier, is the rules and the standards and procedures unclear, and perhaps I need to modify it in some way. Or if there was not an error and there was just a misunderstanding of what was documented or what was coded. So when it pertains to the reasonable and necessary services, physician practices, like I think we discussed this already, that Medicare will only pay for services that meet their definition of reasonable and necessary. So definitely being aware and knowledgeable of the documentation requirements for Medicare is a crucial part, in getting reimbursements for services for beneficiaries that have Medicare. This is pretty common, but clinicians are not able to manipulate diagnosis codes just so they can get the item or that service covered. That is a big no-no. And it's kind of going back to billing for services not covered as if they were covered. So clinicians and even coders are not able to do that. And then the coverage requirements, they are kind of coherent with the coding and billing standards. So there's ways in which you can implement the coverage requirements per payer into those coding and billing practices and procedures in your compliance plan. Obviously put that into that binder as well. That's a great way for a resource that that's how a compliance officer is really seen, as a resource for the facility or the group. So someone that they can come to, they have questions, or they have, they want to report an issue. No matter if, when it comes to the allegations or whatever, that everything is looked at or investigated in a way as if it is a fraudulent activity. You don't want to just brush something off because it doesn't sound like an issue. So that's another way to show that you're really implementing your compliance program. So that's something you need to keep in mind as well. When it comes to documentation, like I said, this is an important part of my current role as an educator. That what are we going to be able to do and work with the provider to really improve their documentation, to really match with their thought process, their medical decision making during that encounter, to be mirror image of what's documented in the record, or what accurately reflects that in the documentation. So well-documented medical record verifies a lot of things. It also documents, what services were rendered, what was done during that encounter. We always hear about that common phrase, if it wasn't documented, it didn't take place or it didn't happen. So obviously you need to document everything that pertains to that encounter. So another thing is that whenever you are trying to improve the quality of the medical record or the documentation, that you can also look at the practice's claims denial rate to the rates of other practices in that same specialty or that same area, and see if there's any outliers, and if so, what are ways in which you can improve that. like I said, is either you can do a focused audit, pertaining to a specific modifier or E&M leveling code, or a diagnosis code. So there's different ways in which you can compare yourself in a way. We talked about in previous lecture a peer review audit. So if you have a lot of other providers, or maybe another two providers in an office, there's a possibility of that, and working together as a team, as a group, to really find ways in which we can improve our documentation. And if there's education that needs to be done on the provider's part, for the coder, or the physician, we need to do whatever we can to really do that. For example, if a practice, has a standard, way that they document, for example, symbols. We're not, as coders, we're not allowed or not able to code from upward and downward arrows. But if a provider has something in their standards and procedures that indicate that whenever a provider documents it this way, it always means this. So obviously, if you have an auditor come in, they need to have those information and those documentations so that you're able to support that in a way. And it's the same way it goes with abbreviations. OIG always talks about, or CMS really talks about, those standard abbreviations. So even like they always say, you spell it out, the whole word, and then you can, in parentheses, use that abbreviation, and you can use the abbreviation throughout the record, and then spell it out again in the assessment and plan. This is a great way, that people from, another provider's office can look at it and say, okay, this is what they mean. You can read the record and kind of give an idea of what it could mean, but it's always best not to make an assumption if you don't have the information to really make a sound decision on what that symbols or that abbreviation means. So for example, in an MI, obviously have you had labs there that that indicate a myocardial infarction, then there's that. But if they just strictly say MI in a physician practice a note, you don't know if it's a myocardial infarction, and if so, how long ago did it happen? Was within that 4-week time frame? If not, then it should be the old MI code. Or does it mean something else? Is it mitral insufficiency? So anything that's possibly not a standard abbreviation that the practice has adopted as to be their standard abbreviation, any of those need to be documented in their standards and procedures, and then given to the auditor, so they were able to use that, and it's kind of a way to show their compliance, that they are, because as an auditor you look at everything, the payers, policies and procedures, the practices policies and procedures. Even if you're able to obtain the provider's contract with the payer, there's different requirements documentation wise when it pertains to that practice. So not always will you be able to have that luxury of having the provider's contract with the payer, but if you do, it's a wonderful tool. So there's many different things that when it comes to standards and procedures, how it's important and a crucial part of everyday activity in the practice. So lastly, dealing with the physician coding and diagnosis, it can also be compared to each physician in the same specialty, like the claims denial rate, to identify any variances or ways in which the provider may be an outlier in a specific area. So there's all kinds of stuff that plays a factor when it comes to documenting and how you can improve documentation based off of your compliance program. So internal guidelines for improving documentation, this is kind of the examples that OIG gives. So obviously it kind of depends on if it's a handwritten note or an electronic note. So the first thing to talk about, is that record complete? Is it legible? So obviously legibility is only an issue when it pertains to handwritten notes. But is it complete? Does it have the provider's signature? Is it electronically signed off? If it's an electronic record. Do they have a chief complaint? That's an important part for an encounter. What is the reason why they presented themselves to that facility that day? And within the documentation, they list a variety of different indicators within the record. For example, we talked about the reason for the encounter, the chief complaint. Any of their history that pertains possibly to this reason why they're here. Any of your physical exam findings. If they've had any labs done before, are they here to discuss those? They're done was done in the assessment. What was your observation as a provider or the clinician for that patient? What is the diagnosis or the diagnoses for that patient, for that encounter? What is being done, to help the patient for those particular conditions, the dates of service, and then the legibility or to able to identify the provider. So a lot of this, especially when it comes to electronic records, even in handwritten records, the name, date of birth, date of service needs to be on every one of these pages. For example, if you were to drop a page somewhere, you have no idea who it belongs to if you don't have those identifiers, on each of these pages. There are practices that only you have the name, date of service. Instead of having the date of birth, they have an age. But they may be the same person that has the same age. You just don't know. So that's why the date of birth, date of service, and their name needs to be on every single page of the encounter form. So OIG has indicated that if these things are not documented in the record, why or what is your rationale for ordering those specific diagnoses or diagnostic tests or other ancillary services? All those CPT and ICD-10 CM codes used for the submission of the claims, are they supported in the documentation as well as in the medical record? Does it have those documentation requirements either, laid out in the provider's contract or the payer's, documentation requirements that you can find on the website? What other health risk factors are identified during this encounter with the patient? What is their progress? Like I said earlier, is their condition worsening? Is it improving? You're just monitoring it. What are their responses to, any treatment plans that they received? Are they having issues with a particular medication? Do you have to make changes to that? For example, with the revision and diagnosis, if you don't have the clinical information, the clinical data to make a sound decision, for example, in staging chronic kidney disease. So once you have all that information, obviously you would change it based off of the different stage of CKD. So, are there any questions before we keep going?
Don't see any yet. You're good.
Okay. So when it comes to the CMS 1500 form, when it comes to the submission of these forms, that is another compliance, possibility or a way to evaluate and monitor successful or an effective completion of these forms. Is the provider what's being done on these forms, or is there proper linking being done with the diagnosis codes? Or do they have the correct location? Are the clinicians indicated on this claim? Are they who rendered the service? Are the appropriate modifiers being appended to the appropriate, certain modifiers are not able to be used or applied to an EM code, and some are. So making sure that, these modifiers are being used appropriately. And then definitely when it comes to pertaining, here we talk about Medicare again, when it comes to their beneficiaries, other secondary insurance coverage. So are claims being denied the first time because it'll be paid by the second carrier. So knowing what's required by the MSP policy or the Medicare secondary payer policy is an important thing for especially a biller or a practice to understand in creating these standards and procedures. So here we talk about the improper inducements, kickbacks, and self-referrals. Like I said before, the self-referrals and the anti-kickbacks, they are also sometimes referred to as the fraud and abuse laws. That whenever a practice is creating or developing these procedures, that they explain, what the Stark law is or the anti-kickback law is, what are ways in which they are doing to be compliant with these laws. Some practices or some groups are able to have a law advisory board, and that if there's complex information or complex scenarios, that they're able to lean on them for guidance. Um, you know, Clinicians and other employees, should be able to recognize when an issue may come up from, a Stark or anti-kickback, you know, problems. Um, and if so, who are they able to go to if they have, these concerns? What is going to be done, if there's an issue arise from these, violations of these laws? What are you going to do to, correct that action? Because these laws really are to prevent overutilization of services and the funds used for healthcare programs. The whole thing is for, especially ABNs, even if a provider believes that Medicare is not going to cover it, why does a provider believe that the patient needs this? Is it in their best interest of the patient rather than, a for-profit kind of thing for the provider or the group? So in the lastly, we talk about, different arrangements. Those complex scenarios, who do they go to for guidance? There are some things that are a bit more complex and that you'll need a law advisory most often. So be able to understand and be aware of these different laws, and how can a practice be compliant with those laws, and for employees to understand, or recognize potential violations and bring them to the attention so that things can be done. If you see issues and nothing's going to be done about it, then you need, it's the, it's just best to report those in a sense so that things can be fixed and corrective actions can be implemented. Things can be done. If education needs to be done again, then so be it. For business arrangements, we talked about this, with the self-referrals, that things need to be at fair market value. There shouldn't be any, things or incentives in a sense that the physician should be getting based off, who are they referring to those services. Like I said, pertaining to designated health services, rehab, physical therapy, labs, things like that. Does the provider have some kind of tie to those other financial, or is in charge of a designated health service? So OIG has listed a couple of particular risks dealing with anti-kickbacks or Stark law issues. So joint ventures, with entities supplying goods or services to the physician or its patients. What is being done? There were different later on in this series, not this particular lecture, but when it comes to the hospitals, we'll be discussing more about joint ventures and what it is. There are some safeguards for different things, and how are things documented or how are things carried out. And it's important to understand and know. How are these contracts being developed or composed? Leases of offices or lease of equipment. are there any referrals, issues there? Are they able to receiving this information, not information, these either the equipment or the rental office space, without within that fair market value? If not, then there's a possible violation. Um, what are they going to do? What is the practice going to do to implement these procedures to address, avoiding these inducements, either with, outside company, vendor, with equipment, rental office space, but even with the patients, what are they doing anything to bribe people to come to the practice? Are they giving things? There's different, laws and regulations pertaining to how much people are able to receive, dealing with, co-payments, deductibles, things like that, or, the practice doesn't take it, or based off financial issues the patient has. There are different laws and regulations pertaining to that. And this is when I said, legal review of complex situations, is a prudent thing to have. Obviously, a small rural facility group may not have that resource, but you see this a lot with more the hospitals and large groups. So the retention of records, there's different laws through HIPAA that indicate how long are records supposed to be obtained or retained in the physician practice. You have your federal and state laws regarding retention of records. And you need to understand, especially in each state, there's different ones. For Louisiana, the retention for records is 10 years. That is not the norm for other states. Usually it's like 6 or 7, and it's kind of what HIPAA is. And with the federal and state laws, they have indicated in these laws that you always go with the more stringent law that protects the health information of the patient. So in this case, that there are cases where state law trumps the federal law pertaining to retention of records. So being aware of what is the law in your state, and that's I found this out when I was taking a health law class in undergrad, and I just thought it was amazing that Louisiana in a sense does whatever they can. I'm not saying anything else but the other ones, but they take the extra precaution, in protecting the PHI or those health personal health information for these patients. So OIG recommends creating a retention of records standards or procedures. How are they going to retain the records? What is their record system? Are they electronic? Are they paper? If so, are the records behind locked doors? What is being done to safeguard patients' privacy, and help protect their private the health information? There are so many cases now where there's a breach, in privacy. One recently in California, where a plastic surgeon's practice and a disgruntled employee stole records. I think like 15,000 records, and financial things as well. So what is being done, to really protect the patient's information, or protect the patient's privacy. That's like the first and foremost goal of HIPAA, and high tech, finding ways in which we can always improve or make sure that that information is secured and protected. And then OIG also recommends, I talked about this earlier, that documentation is done, to report and record compliance activities. What are you doing to improve or implement your compliance program or your plan, your standards and procedures? Also, when it comes to documentations, that anything that you do educational, your internal, external audit results, or any kind of an investigation that's done, what are you documenting those to indicate, if there's a corrective action that needs to take place, or you just if there's an error, what needs to be done there, or you just need to update or revise your standards and procedures. You document those as well. So when it comes to the record retention guidelines that OIG suggests, there are different things. We talked about, the federal and state statutes and the timeframes. That's kind of what they talk about in the first bullet. You know, what is being done to secure their patients' information against the loss, destruction, unauthorized access, in the case of what that was done recently in California, how are things being reproduced, corrected, or damaged? Finding ways in which we can do to, really protect the privacy of our patients. That's why you have all these HIPAA privacy officers at facilities and groups. They kind of work hand in hand. Sometimes the compliance officer is the HIPAA privacy officer, or the director of health information management is also the privacy officer as well. So there's so much information in protecting the safeguards of our patients. So having the right standards and procedures to go along with the retention guidelines is important. Also that needs to be included in your procedures dealing with retention of records. What is going to be done if the practice were to be sold or closed? What's going to happen then? So that's obviously an important thing to have in your standards and procedures. And like I said, when it comes to federal health programs, you need to be able to understand, what's required for these different programs, and that you comply with them. That is crucial if you want to be able to participate in these federal healthcare programs. So we talk about the designation of a compliance officer or contact or contacts, depending on the resources of the facility or the group. Some of the duties that include, the OIG talks about a lot of them, but the general thing is like they oversee and monitor the implementation of a compliance program. So they continually, look and evaluate the compliance program and make sure that things are being implemented throughout the practice. The continual developing and participating in training programs. When a new employee comes on board, they sit through all the HIPAA training, the compliance program training. This is done, once an employee comes on board, and then everyone does it annually. That's what the OIG recommends, and everyone does. And then looking on the OIG's list of excluded individuals or entities. Looking at the employees, all of employees, medical staff, independent contractors, making sure that they are not found on that excluded list. And then, what's going to be done if, you find an individual on there that works in that facility. Usually this is done before a provider or an employee is hired. The facility checks these things. I worked for a company who checked everybody every month. This is a big hospital, obviously, but you need to, keep an eye on this. Obviously, that has issues when it comes to reimbursement if someone is found to be on this list. And like I said, depending on the resources of the facility, you may, mitigate certain duties to other individuals within the practice if you don't have the resources to have one compliance officer. So, there's a couple of things. If this role is, if you have the role inside the facility, or is it being outsourced to an outside party? And if it's an outsourced role, that compliance officer needs to have, that interaction with the practice to address, any issues that may arise. Obviously, you need to have that close relationship if you have an outsourced, if your compliance officer is outsourced. And this kind of goes along with, any outside third party. For example, the billing company, anybody from the outside, those business service agreements, they need to be, signed by these individuals, since they have access to the HIPAA protected information. So definitely keep that in mind too, if it's being this role is being outsourced. And OIG recommends that if you do have an outsourced compliance officer, that you have somebody that works in the practice to kind of be that liaison for the practice and for the outside compliance officer. That they are able to interact and kind of discuss, things that are arising or things that may have shown up on an audit, what can be done to, what corrective action that should be implemented to, correct this issue and things like that. So, OIG covers all kinds of things. If you have the internal individual doing this or individuals, or if it's outsourced, what is going to be done? What is that communication, with the practice and that outsourced compliance officer? So, when it comes to conducting and training and education for a compliance program, um, OIG sees education as an important part in any compliance program, and I think it is extremely, the case. If you are not aware of changes, in this field of coding, it changes all the time and constantly. So, that continual education is important, even if you graduate and you think, okay, well, no more studying or just work. No, it's pretty much like your whole life you're learning. Um, and you continue learning. That's why we have these, CEUs that we have to obtain in order to keep our certifications. Uh, so obviously, education plays an important role in healthcare. That's how these new procedures come about. These new medications. What is being done, to really improve patient care and their outcome. We discussed this before earlier in the lecture, that these programs or the compliance programs need to be tailored to the needs of the practice, like I said, depending on their specialty and the size. Um, and the same way with education. I know when I do my education with providers, there could be tons of stuff that I could discuss with them. That could be all week. Um, so, what is the most important things that you can get to them in that period of time that you have with them? Obviously, when you take time to meet with your provider, in a sense that takes time away from them and their patient. So you need to find ways in which you can um, reach out to the provider and educate them in that shorter period of time, and make sure that they're here for them, that they have any questions, that you're able to go to them, or they're able to come to you, or whatever, via email, phone call, or in person. Um, and when it comes to education, compliance professionals, they look to make sure that these educational opportunities leads to a better understanding of those standards and procedures or the compliance program as a whole. And OIG looks at, three different things in developing, educational objectives. They look at to see who needs training. Is it just coders, is it billers, is it the providers, it was the whole group. Um, Determining what type of training that best suits the needs of the practice. And then finally, when and how often does education need to take place, and how much each person needs to receive. So, definitely pertaining to compliance overall, OIG recommends it to do annually. And then obviously, when it comes to new hires, they do it upon their as part of the onboarding process of the practice. So, like I said, we kind of talked about this a second ago, that the new employee needs to have that compliance training as soon as they start, and then everyone else on an annual basis. And some of the things that's included in compliance training, the importance of a compliance program, the operation, how does it work, what is its purpose, and then the consequences of not, following or being compliant with those standards and procedures set forth by the practice. And then, the importance of the role of the employee in the operation and the implementation of the compliance program. Um, once this is done, it's best to keep the documents, if there's training done and there's a physical copy of, the training materials, keep that. Also, document the training was done, as electronic kind of thing, how they keep track, or, they do something else. So everyone comes together for, annual compliance training, and things need to be done that way. So when it pertains to coding and billing training, they also suggest, OIG suggests, the annual training for when it pertains to coding and billing, specifically for federal healthcare programs. Definitely pertains to the staff that does the coding. So a lot of nowadays, the provider does the coding. So obviously they need to be aware of, the changes, or, they need to go through training as well. Some of the external and internal protocols that the OIG recommends, the coding requirements, are they going to have like a certified coder, or, someone that's just trained in it? Um, you know, who's going to be doing it? Is it the provider or somebody else? If the provider is doing it, is somebody, that is a coder? Are they behind kind of, doing a quality assurance, making sure things are done properly? Um, the development of a claim and the submission processes, the processes, like what is being done, in developing that. Um, you know, what's going to happen or take place if an employee signs a form of for a physician, without their authorization? What are those consequences? What's required in documentation to indicate that services were rendered were actually, medical necessary? Um, you know, and then, the legal or those consequences, for submitting claims that were falsely, documented or submitted. Um, and then, proper billing and submission of accurate, claims for services that were rendered, especially when it pertains to federal healthcare programs, Medicare, and Medicaid. So like I said, the same thing that happens with a lot of these educational, opportunities or objectives is that it's done annually. This is what OIG recommends. Some do it quarterly, um, some do it, twice a year. So, kind of whatever is the, standard of that practice, when it comes to training or annual training. And the next thing is when it comes to like new billers or coders, for a facility or a group, the OIG recommends that they work under an experienced employee or a coder, if that's possible, until their training is complete for however long that is. If you're working for a hospital, some facilities and groups have, a track, for, new coders. So they'll start off with easier cases, and work their way up to those complex cases. That's kind of what happened for me when I worked at a surgical hospital, is that they had that, that plan in place, for new employees, and they work under experienced employees. So that's an important thing to keep in mind as well. Do we have any questions before moving on?
Yes. Let me read the
Okay.
first one. If the billing slip uses the wrong CPT procedure code, can a certified coder bill out the correct CPT code to match documentation? Our billing slip cannot be changed once closed and sent to billing office, so they won't match.
Well, you have those instances where, you find errors, there's that corrective claim, kind of thing. But, whenever it comes to, um, you know, auditing and, that controlling or the, monitoring part of a compliance program, um, you have that retrospective and the, prospective, excuse me, um, audits. So you can catch things like that before things are submitted. So, what are, maybe perhaps your standards and procedures need to be, not manipulated, but, altered in a way, or, improved, changed in a way to, can find a way to correct that action. So that could obviously if you have to do is submit a corrective claim that takes more time. Then that slows down the process of being reimbursed for those services, and you don't want a provider to come to you and say, "Hey, where's my money?" So there's that. So perhaps standards and procedures need to be developed more or changed and revised to fit that particular issue.
There's another one, but I'm going to have to get some clarification because I think we're missing some English on it. That's it for now.
Alrighty. So the next thing is, responding to these detected offenses. I've already talked about, how to develop a corrective action based on, what you found already, either in that internal or external audit results. So like I talked about before, that a compliance contact or the compliance officer needs to look into these allegations, determine whether if a significant or a huge violation happened or took place, and if so, what steps need to be done to correct this issue. That's kind of what the corrective action is. If there's an issue that arises and it's an error, what needs to be done, to correct that. So there's certain things, in a EMR or EHR that there's flags that are warning signs that may pop up depending on how it's formatted. So if OIG kind of talks about compliance plans and creating monitors and warning indicators in your sentence and procedures. So for example, if there's a high or unusual change, in ways that things are being paid or transactions that are being done, obviously that's probably a good indicator something's going on. Or changes in the coding pattern is different. Either it's the CPT, HCPCS, or the ICD-10 codes. So that's another thing you can think about. And then changes in the number of denials or rejections. That can be an indication that something's going on. Is there a new code that's came out that we're unaware of or that we're not using? That's why that continual education, or that you need to really understand in those changes what's being done, what's those required documentation requirements by each of these payers. So obviously if you have a large number of rejections for a certain time period and that's not normal, then there's probably something wrong, and then you need to look up the policies and procedures of a payer and see, okay, what's going on, were there any changes during that time frame. Okay, so when it pertains to the detected offenses, we talked about overpayments already. If things are found, it needs to be reported within that 60 days of finding out that error. Are there potential criminal violations? Is there needs to be a referral or the self-disclosures to a government authority or law enforcement agency? Other fraud instances, the case of those breaches due to that employee, that disgruntled employee, obviously there'll be criminal violations, but you don't know how much they're going to be. So OIG doesn't have all this stuff, to scare people, but it really helps, compliance, and overall it helps protect the patients. And that is an important part of the compliance program. That's what they already stated before, that the patients is the first and foremost the important part of having a compliance program. It protects them. It keeps them safe. So it's important for employees to understand the consequences for not being compliant with the standards and procedures set forth. What needs to be done depending on the violation of misconduct. Are they going to be restrained? How are they going to be disciplined based off of that offense, or not being compliant with the standards and procedures? So we have open lines of communication. Um, OIG talks about, keeping those open lines of communication, and this really does help prevent compliance problems, because you're discussing these issues, and that's why, having that open line of communication, people know who they need to come to when they see issues or they think something's going on, and the officer or those compliance contact or contacts, look into or they investigate the issue or the allegation. And they have that, the open door policy I talked about before, that they know who they come to. They can come to them with anything they think that may be going on. When it comes to small rural areas, protecting the anonymity of the person that's reporting this may be a little bit difficult, to keep that, pertaining, that's just the unfortunate thing of small areas. Um, but there are laws set in place that employers are not able to retaliate um, an employee based off, reporting what they think is an issue, what they believe, be a violation of, either the anti-kickback, the Stark law, a possible fraud, or things, something going on. So there's no way that they can retaliate against the employee. And the important part is for them to know who they can turn to when it comes to, those having an open communication with your employees with that practice. So there's a couple of things that the OIG recommends when developing, or creating an open line of communication within the practice, that you use or that you create a user-friendly process, that that there are the ways that you can report these issues. It's easy to be able to report. It's not complex. It's not difficult to report. And it's important for the employees to know that they have a duty to, report issues that they see. Um, and if there's things in the standards and procedures that need to be altered, or revised, in a sense, that needs to be that needs to take place. Um, are there things in there that, discusses disciplinary actions for, reporting, when it comes to pertaining to reporting erroneous or fraudulent conduct? Obviously there's violations within the compliance program there. And there's no retribution for reporting conduct. That's what I was talking about. There's no retaliation from the employer, for, reporting these things. Because the sole laws, protecting those employees that report them. So we talked about this a little bit before. Having these well-publicized guidelines. What disciplinary actions take place if you're not being compliant. So whenever you have these, when you have or enforcing your compliance program, in disciplinary actions, this adds credibility and integrity to your compliance program, because it shows that you are fully implementing your compliance program, that no one is, not subject to it. So if you see, or if for example, if a compliance officer or somebody in management is not being compliant with the standards and procedures of the facility or the compliance program, then obviously people, the coders or whomever that's under the direction of the managers, and they see this, then obviously that loses the credibility of the compliance program, and things need to be done to correct that. So what procedures are being done to enforce or discipline individuals who violate, the compliance program of the practice, or those standards and procedures that are set forth by the practice. Um, you know, it kind of OIG recommends, building or creating, a way in which if other warnings or things like that that individuals receive before, terminating an employee for not adhering to the company's policies and procedures. So here are some of the disciplinary actions that take place during this in this section of the compliance program. So are there warnings, are there reprimands, so it's a written or oral probation periods. For example, if you have issues maybe not pertaining or not obtaining your required, production levels. So what's needed to be done, education maybe, or, they need to be put on probation and figure out what's going on, or they're going through something. Having that open, communication is important. Somebody may be going through something and that you're not aware of, they don't want to discuss it. But it does, have an impact on their daily, activities at the work. Are there demotions going to take place if it's in a managerial role? Are they going to be temporarily suspended? And also leading up to termination. And then, are there damages, due to not being compliant with the company's policies and procedures? And if so, are there any criminal investigations that it's being done on an employee? Is that why they got terminated? And are they being sued, criminally for whatever action it may have been? So whenever, like we were talking about OIG suggests or recommends, to have documentation of everything to show that you're fully implementing your standards and procedures throughout the whole practice. So some of the things that they listed, they said name the date of the incident, what took place, name of the reporting party, and name the person responsible for taking the action. What was the follow-up action? What was that corrective action? What took place? Whether they may put on probation, or extra educational training needs to be done. What's going to be done, to correct this action. So those 4 things are important to document when an individual is non-compliant with the company's policies and procedures. So that is it pertaining to the OIG's compliance program guidance for individual physicians and small group practices. So we discussed ways in which to develop a compliance program, and different parts that make up the compliance program for this particular topic. So you have your auditing and monitoring of what's being done. You have building that baseline audit, and then from that audit, creating and developing those standards and procedures that fit the needs of the practice and the specialty. Those things that are found during that audit, and then designating an individual as the compliance officer, or having other individuals, if you're in a small rural area, different compliance contact or contacts. How is the training and education going to be conducted at this practice? What is going to be done to respond to detected offenses? And how are they going to be able to correct those actions? And it's really important to have that open line of communication that, you may not, especially in a small group or a small rural area or hospital, you may not get along with everybody, but having that open line of communication is important. Especially, they even talk about this in other parts of the compliance, study guide pertaining to this credential. How the importance of an exit interview with an employee. That opportunity for for that employee to to tell that compliance officer or the contact, if there was any issues they saw, any compliance issues that may arise, and then finding ways in which you can enforce those disciplinary standards within those guidelines that you have well publicized to your employees. That is it. Do we have any questions, either about this lecture or about the exam itself?
If you have any questions, please ask them. We'll stand by here if you got any more based on what Schuyler has shared with us here tonight. Doing a great job here, Schuyler.
Thank you.
Most of the time, I think, if I can interpret this question, I think emergency room stolen records would normally be hard to steal, but I would assume that most of the time security would take care of that, right?
Yeah, emergency is a little bit kind of a chaotic environment, but there are ways in which a facility can implement, protect the privacy of the patients. You have those dividers. Obviously, whenever it's a jam-packed room, it's kind of hard, to protect the privacy in that way because everybody can hear everything. But really protecting the records, has all their information on there. It's really important, especially when emergency rooms, they'll have those retention records, ways in which they're implementing their kind of standards and procedures for protecting the privacy of their patients.
Yep, makes sense. All right, well, I don't see any more questions that have come in since we asked, so I think we're officially done. Any last words here?
No, definitely reach out to me if you have any questions. We have some more lectures coming up for our compliance course that we're developing, so definitely stay tuned for that. And of course, any of our other lectures that we have throughout the week. So definitely look at the CCO's calendar that they have on the website and stay up to date and make sure that if you want to attend, you can look at these events that happen throughout the week and see which ones you're able to attend. And it's important, even if you're not, want to take the credential for whatever it may be pertaining to, but it's an important part of, that continual education, being aware of certain things. So, even if you're not going for that, it's really cool to, attend something. It may be something that you'd be able to bring back to your particular group. So that's kind of the importance of, going to your local chapter meetings. I'm actually going to go to mine on Thursday. So it's, do what you can. I know we're all busy, but, in this field, it's important to stay up to date and kind of, learn as much as you can.
I just pasted also the link to our topic request forum on cco.us. So if you want to check that out, if you come up during the week, another question you'd like to ask Schuyler or the rest of the team, by all means, go over to cco.us/topic-request. And that will help everybody else as well, as we'll explain that question and do some research and get it out to everybody.
Yep.
Okay, so thank you, everybody. I think we're done here tonight. So thank you, and we will talk to you soon. And thank you, Schuyler, for being with us tonight.
No problem. I hope you all have a great evening.